Okay, good evening, everyone. My name is Sarah Imbro, and I'm the Executive Director of ALS United of Georgia, and we're so happy to have you all here tonight. I see lots of people chatting in, so we have a variety of people from across the state, so it's so great to see you all. I'm actually going to hand this over to Stephanie Medill, one of our care services coordinators here. Many of you might know her if you attend the Emory ALS clinic. She is in attendance in that clinic and leads our Marietta and Gwinnett support groups as well. So Stephanie, I'll let you kick the program off tonight and introduce our guest.
Thank you so much. Good evening, everyone. Thank you for joining us tonight for our educational webinar hosted by MT Pharma in partnership with ALS United of Georgia. Like Sarah said, my name is Stephanie Medill. I'm a care services coordinator here at ALS United, and I will be co-hosting tonight with Sarah Embrow, who just introduced herself, and Anita Flowers, our senior care services program manager, who you all probably know as well. We are so glad to have you with us as we continue our shared mission to support people living with ALS and their families through education, care, and community. Before we get started, I'd like to go over some housekeeping notes to minimize background noise. If you all could remain muted during the presentation, that would be much appreciated. And once our speaker has finished, we will open it up for a Q&A session. If you have any questions at any time during the presentation, please type them into the chat box, and we will make sure to address as many as we can at the end. So now it is my pleasure to introduce our guest speaker, Kristen Loechel. She is a registered dietitian and nutritionist with over 15 years of clinical experience in both the outpatient and inpatient settings. She currently works as the dietitian for the Emory ALS Center and in diabetes education. Kristen is deeply passionate about supporting the ALS community and helping individuals navigate the unique nutritional challenges that come with this disease. You have probably seen Kristen at the Emory Multidisciplinary Clinic if you have been there. She works closely with the Emory ALS team to identify those at nutritional risk and develop strategies to improve nutritional outcomes, all with the goal of helping people with ALS maintain the best possible quality of life. So please join me in welcoming Kristen Loechel. Thank you so much.
Hi, everyone. I'm looking at the chat box and seeing the names that I'm reading here, and I feel like I recognize a few of you. So if you've seen me before, hello again. I have a PowerPoint presentation. I don't know if I'm able to share it or if you guys need to share it. Do you know, Stephanie?
Go ahead and try, Kristen, and if you
Okay.
can't, then I can do that.
Okay. Let's see if it'll let me share. Did it work?
Yes.
All right, yay. Okay. So I'm so excited to be here with you guys tonight. I was really excited for this opportunity. I've been to the Marietta support group for the last couple years and also the one in Gwinnett. And it's really fun to kind of interact with you guys and not as so much of a, kind of sterile clinical situation, but a little bit more like the support groups. It's kind of fun to hear you guys interact and talk with each other about all this. So I'm excited to kind of do this in a Zoom setting as well. I'm trying to see here. There we go. All right. So as Stephanie said, I am Kristen Loechel. I made this little slide just kind of a little bit about myself. You can see my beautiful little family here. So as Stephanie said, I'm a registered dietitian for the last 15 years. I got my undergraduate degree from University of Georgia, go Dogs. And then I went on and got my master's degree at Florida State. My first job was inpatient at the main campus at Emory. I did that for a few years, and then I moved into an outpatient setting, and I've kind of ran the gamut of all the different kind of disease processes that nutrition can touch. I worked with the transplant team for a while. I am a certified diabetes educator. And so I've really been working in diabetes probably since about 2013, but also things like kidney disease, weight management, malnutrition, kind of you name it. I've probably at least dipped my toe in it. I joined the ALS team here at Emory in 2021. I also, as Stephanie said, worked in diabetes education when I'm not working with the ALS clinic. But I joined with you guys a little over 4 years ago. And honestly, this isn't me just saying this because you're who I'm talking to right now. This has been my favorite role as a dietitian in the last 15 years. So I love being part of this clinic. I love being part of this community. And I really do want to help and support as much as I can. Okay. I currently live in Roswell. You can see my husband and my 3 kids, very active. They keep me busy when I'm not working with you guys. And then you see my 2 little not so active older dogs. The one with her ears flipped up on the beach, she's 18 and a half. And then the little dachshund here, 17. So, you know, um, we're kept busy taking care of them too. All right, so I'll go to the next slide. And Stephanie kind of touched on this. Um, my role with the ALS team really is to try to make sure that you guys have optimal nutrition. Okay, we know that this disease comes with a lot of challenges, and I want to make sure that we're addressing those challenges and meeting them head on and doing everything that we can. Um, I will kind of work closely with the ALS team, with the speech therapists, with the doctors and the social worker and our nurse, Jean, if you guys know her, and making sure we get any nutrition interventions in place when we need to. Okay. The most likely you'll see me in person at the clinic. I do attend every clinic that I'm physically able to be at. So we do that, 2 Fridays a month. And then I also call people on the phone, or I can do Zoom chats if you prefer to kind of do a face-to-face interaction. So there are other ways to get in touch with me outside of just the clinic if you have something that comes up between multidisciplinary clinic visits. Or, if you're somebody that's maybe not necessarily connected with Emory, there still may be a way for me to chat with you, or we can get you in touch with another dietitian if we need to. Okay. All right. So when I see people, especially maybe somebody that's newly diagnosed with the disease and we're seeing them for the first time, there's really 5 main kind of categories that I look at. And I make sure that we're addressing these situations and trying to meet these goals as best as we can. So a lot of the questions that I ask are related to these 5 nutrition goals. Okay, we're going to go through each of these in the next few slides, but you'll see enjoy eating, maintaining body weight, avoiding choking on foods, getting enough hydration, and then avoiding constipation. Okay, so a lot of the clinical questions that I ask people are kind of related to meeting these goals. So the first one, enjoying eating, okay? You see my first bullet point here. Eating should be a pleasurable part of your day, okay? And, prior to this disease, for most people, eating is a very pleasurable part of the day. And I'm hoping that it continues to be a pleasurable part of your day with the disease as well. But we know that for a lot of people, especially if we're having the bulbar onset side effects, that this does become a bit more of a challenge, right? It could be because of, limb function and we aren't able to prepare foods that we used to or feed ourselves like we used to. It could be because the swallowing is becoming a little bit weaker and harder. We're more fatigued. I have some people tell me they just really lose their appetite. So there's a lot of things that could make it a little bit more of a challenge to enjoy the eating, right? Ideally, we want meals to be consumed in about 20 minutes or less. Okay. And the reason that me, along with our speech and language pathologists, kind of have this rule of thumb is we feel that if it starts taking longer than that, it's just an indication that there's maybe some things that are coming up, right? It could be that we are experiencing more fatigue. It could be that our swallowing muscles are getting weaker, and it does start raising some red flags and maybe some risks for an increase of choking on our foods, okay? Which kind of gets back to, well, that's not an enjoyable way to eat, okay? My goal is to see people eating at least 3 meals a day. mostly because it's hard to get the amount of calories in that we need to in order to maintain our nutritional status without eating 3 meals. Okay. Most of the people I work with, I'm encouraging at least 3 meals and oftentimes snacks in between meals. And that kind of gets back to that second bullet point of eating meals for 20 minutes or less. It might be hard to get all our calories in if we're just eating 3 meals and limiting it 20 minutes. So sometimes we need to have kind of smaller meals and then have 2 or 3 snacks in between so that we can get the calories in that we need. Okay. I don't have this is the diet you have to eat because you have ALS, right? Everybody's nutrition is going to be, their nutrition needs are going to be slightly different based off of maybe other comorbidities that they have or their age or where their weight was prior to ALS. You know, there's a lot of factors that go into how much nutrition and the types of nutrition you need. But in general, I like people eating as balanced of a meal as we can. Okay. And to me, a balanced meal means you're probably consuming at least 3 different food groups at a meal. Okay. So if we think of kind of 5 main food groups, we've got fruits, vegetables, things like starches and grains, milks and yogurt, and then our protein sources. So of those 5, we want to try to make sure there's at least 3 of those present at a meal, or else I don't consider it a meal. I consider it more of kind of an in-between snack. But making sure we're getting, several food groups at a time better ensures that we're getting all of the nutrients that our body needs. Also making sure we're getting things like proteins and fibers, which are also really important. And I'll touch on fiber a little bit more on another slide. Okay. Let's see. Is it gonna move? There we go. All right. My next goal here is to maintain your body weight. And so probably every time you come to the multidisciplinary clinics or you go see your ALS doctors, they are trying to check your weight because what we see is if we are maintaining your weight, we tend to kind of halt the progression of the disease a little bit better. Okay. Weight maintenance, slower progression, and also just a better overall quality of life with the disease. If we start seeing a rapid weight loss, we tend to start seeing some other functional declines go along with it. Okay. Many people with ALS do end up with some weight loss, and it can be for a lot of different reasons, right? It can be because of our appetite going lower. It can be because of the swallowing difficulties. It can also be because for some individuals, ALS can be hypermetabolic, meaning that we're burning more calories at rest than we used to. Okay. And sometimes I have people come into clinic saying, well, I'm not moving around as much as I used to, so I shouldn't need as many calories as I did before. And while I understand the logic, but there is that hypermetabolic piece of the disease for a lot of people where we really do need these extra calories, even though we're maybe not moving around as much as we did. Okay. Of calories, calories are made up of carbohydrates, proteins, and fats. All of them are important to be consuming. When there's been kind of research done on, hey, what's a way that we can help maintain people's body weight through nutrition? A lot of times it kind of shows if we eat kind of what people would call junk food or junky carbohydrates, right? Maybe kind of the higher sugar, more refined grains. We tend to find that people that are consuming these foods tend to maintain their weight better. So that kind of goes back to, I don't really put people necessarily on a strict diet with ALS because what we tend to find is people start losing weight when they kind of self-impose restrictions. And I oftentimes am encouraging people, it's okay to have your sugary beverages that you're enjoying. It's okay to have desserts. It's okay to have ice creams. I actually kind of encourage you to have these. Now, do I want you only eating, junky foods necessarily? No, I still want there to be some balance and some nutrition in the foods that you're eating. But on top of that, we do encourage some of these kind of higher calorie foods that you for most of your life are probably told to limit. Okay. Um, Fat calories, fat has twice as many calories as like our proteins and fats. So when we're trying to just increase overall calorie intake, fat sources can be very, very helpful. So that's, making sure that when we're cooking foods, we're cooking in butters and oils, adding cheese to our vegetables, using gravies and sauces that are going to have some higher calories in them, salad dressings, whatever, that will kind of give you those extra calories. And then protein. People do oftentimes come into the clinic saying, oh, yeah, I'm drinking a protein supplement now, right? Oftentimes it's like a Premier Protein, if you've heard of those. And those are these really high protein supplements, which is great, but they also tend to be kind of low in calories. And so they're not helping getting those extra calories in like we want. Protein is important. Your protein needs are maybe a little bit higher than they were prior to the disease, but you really have to have enough calories along with the protein in order to kind of preserve the muscle that you can. Okay. Um, so I don't focus as much on protein as you might think. Protein, like I said, is important, but so is overall calorie intake. Okay. Uh, when I'm kind of choosing maybe some nutritional supplements for people, my biggest rule of thumb is that I want it to have at least 350 calories or more per container. Okay, so things like the Premier Protein, or you might find like a Boost High Protein or Ensure High Protein. You'll see that these do have like that 30 grams of protein, but the calorie level is like 160, 170. And what I really want is there to be protein in those, but also at least like 350 calories. Okay, so if I look at like Boost Plus and Ensure Plus, those are about 350, 360 calories. And then the protein in those is about 16, 17 grams. Um, if people still want to try to be getting that like 30-gram protein mark, Ensure Complete does have 30 grams of protein along with about 350 calories. Okay, so that's one that I oftentimes recommend. That's one that you will most likely be able to find like at the grocery store or Target or Costco or wherever. So if you want to try to find something in person, that's one. These next ones that I have listed here, Enu is how I pronounce it, ENU, Kate Farms, Reason. Those are ones you won't be able to find like in the grocery store. They are online. You could find them on Amazon. Um, of all of these, which one do I think tastes the best? Probably this one right here, ENU. Um, and it's really high calorie. It's an 8-ounce carton, so 1 cup, and it's like 410 calories. So it's even a little bit higher in calories than the Boost and the Ensures. Kate Farms is like 450 calories if you get the one that says 1.4 next to it. Reason is also around 400 calories. These are a little bit bigger containers. They're like 11 ounces versus 8 ounces though. Okay, but those are all options. If you want to choose, like I said, the Premier Proteins or like Orgain is another one you might find in the store, Fairlife, but they're a little bit lower in calories, say like 150 to 250. What I tell people to do is just mix them with like whole milk, ice cream, something that's going to put more calories in addition to the shakes. Okay. I've also put in here just a few like smoothie recipe ideas that will all be kind of high calorie. If you guys want to take a screenshot while it's up, you can. But these recommendations came from like an ALS nutrition organization. And so these are just kind of some different ideas if you wanted to make like a higher calorie smoothie at home. I have a lot of people kind of asking for liquid calories because they're easier to consume when your appetite's not as good, or if you're having a lot of trouble with solid foods, the liquid calories can just be a little bit easier as well. Okay. All righty. That kind of leads into the next goal. And this one is the one that I work really closely with our speech and language pathologist, is we really don't want people choking on their foods. Okay. And I'm sure that this is something that has been brought up at any of your clinic visits or anytime you meet with your doctors, is they'll probably ask how your swallowing has been going. Have you noticed any changes? The biggest concerns here are obviously getting any of the food particles or bacteria that go into our lungs and cause aspiration, which can lead to infections in our lungs, right? That's kind of our biggest concern. But what I look at from a nutrition standpoint is if we're choking a lot on the foods that we're eating, we're likely not consuming as much as we once were. And that again leads into weight loss, not enjoying our foods. Okay. Um, some of you might already be experiencing these symptoms, but things that we kind of look for are if you're doing some throat clearing or coughing when you're eating, or sometimes people say this happens just on their own saliva. If when you're eating or drinking, you kind of get like a wet vocal quality, so it just kind of sounds a little gurgly. If people start having a little bit more drooling out of their mouth, or if you start noticing certain food textures don't go down as easily as they once did. The ones that people kind of describe as being more difficult are things like dry and crumbly foods. So, like a cracker, chips, things like that. Big pieces of meat that are a little bit drier or tougher. So, a lot of times, steak or like a chicken breast are a little bit tougher for people. Um, lettuce, a lot of people complain that lettuce is really difficult. Sometimes it's foods that have a lot of different textures in the bite. So like if you think about like a soup that has liquid, but it also has like veggie particles in it, just kind of the liquid and the solids all together in your mouth can be a little bit harder to swallow. Or things that break up into really small pieces. So like rice, oftentimes people say it kind of leaves a like a residual in the back of their throat. Okay. Um, and then another sign we talked about earlier is if meals are taking like 30 minutes or longer to consume, that's indicating to us there's probably been some swallowing impairment. Okay. And again, this is when I work really closely with our speech and language pathologist, because that's oftentimes who's going to say these are the safest textures for you based off of what I'm seeing, either from a clinical swallow evaluation that they'll do like in their office, or I'm sure some of you have had that modified barium swallow study that really looks under your looks at your swallowing under an X-ray so that you can see really what's going on. Okay. Most commonly, I see people kind of being told, eat softer foods, cut things into small bites, maybe take some small sips of liquids between your bites just to make sure everything's going down okay. Um, there are handouts that kind of describe this, but oftentimes people know, right? They can kind of figure out this food worked for me, this didn't. Oh, when I add gravies, this does seem to go down a little bit easier. But like I said, if we need kind of some guidelines, there are always handouts that we can give out for that. Okay. My fourth goal is I want to make sure that people are staying really well hydrated. Okay. This becomes a really big challenge. I would say this is one of the top things that I notice people really struggling with. Because this can happen, let's say, even if we're not having a lot of, swallowing difficulties, but I oftentimes see people that are having mobility issues and it's harder for them to get to the toilet. They kind of go, well, if I drink less, then I don't have to go to the bathroom as often. And this is a big ordeal. I'd like to minimize how often I have to go. But it's not good for our bodies to become dehydrated, okay? Even if we lose a small amount of the body water in our body, 1.5% body water loss shows physical and mental decline. So people they feel more fatigued, they just can't get around as well, they're not as mentally sharp when they're dehydrated, okay? We also notice that sometimes the mucus gets a little bit thicker. Their saliva quality is actually a little bit lower. So your mouth might feel dry even though you have a lot of saliva. When people are dehydrated, it leads to constipation, which is going to be my next slide. But it's also actually really hard on our kidneys. Okay, so we can actually cause some damage to our kidneys if we're dehydrated. Okay, it increases the risk of infections like UTIs. So we do want to make sure we're keeping our hydration up as best as we can. Okay, a very, very minimum that I want to see is 48 ounces. Okay. And that's really for women, 64 ounces if you're a man. So 6 to 8 cups of fluid per day. If you're a little bit taller, if you have a little bit more body mass on you, you probably need more than that. But again, that's my very, very minimum. And you notice I say fluid, I don't mean just water. Okay, a lot of times people come in and they're like, oh, I don't drink a lot of water, but then they list off the other things they drink, and I go, that's fine, that's still hydration. Okay, so you see here, I said all liquids count, dot, 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 except alcohol. I'm not here to say you can't have alcohol, I'm just saying you don't get to include it in this 6 to 8 cups. Okay, but of course, water, juices, sports drinks, right? Gatorades, Powerades, Body Armors. Any of your sodas, it could be regular sugar or diet, lemonades, coffees, teas, sweet teas, etc. Any of it counts. It's the base of that is mostly water. So you can certainly count those. And oftentimes we find that people do drink a little bit better when they drink things that have some flavor to it. And also people kind of comment that, plain water is harder for them to swallow, but if they have something that has flavor to it, it's a little bit easier for them to swallow. So I encourage people to have things that have some flavor to it. And oftentimes I encourage you to have something that maybe has some calories to it. If we're in that situation of needing to maximize how many calories we get in, it's good to be getting them, when in something that we need to be drinking anyway. I didn't put it on here, but also like our nutrition supplements like the Ensures and Boosts and etc. Those will count towards the fluids. You can also try to think about, okay, well, what foods can I be eating that have a lot of water content in them? Okay, so things like canned fruits have water content, or canned veggies have water in them. Obviously, like a smoothie, the base is going to be a juice or a milk or something. Same with shakes, a drinkable yogurt, and again, the nutrition supplements. So really, any of these can kind of count towards that hydration if you need to. The two best ways to make sure we're getting enough hydration, or to kind of tell if you're getting enough hydration, is you pay attention to the color of your urine. Okay, we want it to be a pale yellow. If we wake up in the morning and it's a little bit of a deeper yellow, it's probably fine, but as the day progresses, you want it to become more of a pale yellow. I know sometimes people take medications or supplements that can alter the color of their urine, so that might not be quite as accurate. But for most people, paying attention to the color gives you a good feedback. Okay. The other way that I can tell if you're getting enough hydration is if you're constipated or not. Okay. People with ALS are twice as likely to experience constipation in relation to the general population. Okay. Biggest reasons I see because of this are because of the nutrition not going as well. We're not getting as much fiber content in our diet, or again, that not getting enough hydration, and then also a decrease in mobility. Okay. The patients that I see that are still able to kind of get up and walk around some tend to have less constipation concerns. The people that are more in a wheelchair tend to have a little bit of a higher incidence of constipation concerns. And it's really just because getting up and moving around does push things through our digestive tract and helps us with digestion. Okay. Not much we can do about that piece of it, unfortunately. So I do focus more on making sure there's enough fiber, making sure there's enough hydration. Okay. You can see down here, I already told you the 48 to 64 ounces of fluids in the day for the hydration piece. And then fiber recommendations. And these are just general recommendations for the general population, is to get somewhere between 20 and 38 grams of fiber per day. Okay. The 20 to 25 gram range is more for women. 30 to 38 grams a day, that's more for men. Okay. What does 20 grams of fiber look like? It's going to depend on the foods that you eat, but for example, like a medium-sized apple is about 4 grams of fiber. Okay. A half a cup of a non-starchy vegetable is about 2 grams of fiber. A half a cup of beans is about 7 grams of fiber. So it just kind of depends on the food, but fiber is found from our plants. So that kind of gets back to why it's so important to be eating balanced meals and getting in these plant-based foods, is to be getting that fiber. Okay. That's the first thing I encourage, like in the morning, doing oats or oatmeal, adding fruit in a couple times a day, eating a serving of vegetables, choosing, whole grains if we can. But oftentimes I am recommending people also use a fiber supplement to get a little bit more. The most common one I encourage is prune juice, and that's because it is a fiber source, but it has a fiber in it called sorbitol that has a natural laxative effect to it. So when people are kind of like trying to shy away from needing a medication to help with having a bowel movement, I oftentimes am saying, well, let's try hydration, fiber, and prune juice first and see if that works. Okay. Um, I have some people that will say, I will not eat vegetables. It's just not something I'm going to do. And then that's when I'm also kind of saying, okay, let's see if we can get something like Benefiber or Metamucil powders, mixing them into something that you're already eating, right? If you're eating oats or oatmeal or grits or something, mixing it in there, mixing it into your coffee, mixing it into a soup, somewhere where you won't even notice that it's there, but a way to get a little bit more of that fiber. Okay. If swallowing function is still intact, fiber gummies is another kind of, fun way to get a little bit more fiber in. If we do all of this and really just that dysmotility is going on, things are just not moving through the digestive tract like they once were, oftentimes we do need medications to help. I have people do try a stool softener. It works for some people, but I do find that laxatives are much more effective because a lot of times it is that it's not so much that the stool is too hard. It can be, but that's part of it, but also it is just our muscles are having trouble pushing it out, and that's where the laxative comes in. So the two most common ones I recommend are Senna or Miralax. A little bit of a more, I don't want to say hardcore, but one that kind of works a little bit faster is like magnesium citrate. So that would be kind of the next one if the Senna or Miralax aren't working. The most common mistake I see people do is they kind of go, ooh, I haven't had a bowel movement for 3 days. Let me take a dose of Miralax. Instead of saying, oh, I'm getting constipation, instead of me waiting for the constipation to happen and then treating it, let me try to prevent it. So oftentimes I'm telling people, why don't we go on a regimen? So let's maybe do the Miralax every day, every other day, do a half a dose, do a full dose, right? You just kind of try to adjust the dosage to meet the desired results. Okay. Uh, in a perfect world, we have a bowel movement every day. We have a bowel movement at about the same time every day. And it's pretty easy to get out, meaning it shouldn't take more than 2 minutes. Okay. If it's not that easy, then there is kind of signs that maybe this is becoming a little bit of an issue. Constipation, by definition, is when we've gone 3 or more days without a bowel movement. Okay. If this is happening, these tricks are not working, then I do want you to get in touch with the ALS team and kind of get some advice from a doctor. I have had people need to go to the emergency room to get it treated. Okay. And I don't want it to get to that point. So we try to do all of this as best we can, but it's not good for our bodies to be constipated. When I hear people say they haven't gone in 7, 10, 12, 14 days, that's when we probably need to get a little bit more of a harder core intervention going. Maybe even going to the ER, getting some IV fluids, getting disimpacted. Okay. All right. So those are my 5 main goals. Oftentimes, I am also consulting with people about a feeding tube. Okay. And I'm sure some of you that are on this call have a feeding tube. If you don't have one currently, it's maybe been brought up in some of your visits with the doctors. Maybe you've already kind of heard about some of the indications for why we think a tube feed or a feeding tube would be beneficial for you. The biggest one is monitoring your weight. Okay, so if we're noticing a progression in weight loss, and a good rule of thumb is if you've lost 10% or more of your baseline weight. So if your usual body weight prior to the disease was, say, 200 pounds, and you've lost 20 pounds, right? That's 10%. If we're seeing that, it's an indication to us that you're not able to maintain your nutrition solely through oral intake. Okay, so weight loss is a big thing that we look at for placing a feeding tube. And also an increase in feeding difficulty, an increase in swallowing difficulties, if people are describing decrease in appetite, if people are experiencing that fatigue at meals. Okay. So these are all things that we're kind of asking about when we're chatting with you. Let's say your nutrition status has been actually pretty good. Your weight's maintained. You're not noticing a lot of swallowing issues. You're eating kind of your normal diet. But when you go into the clinic and get your breathing numbers checked, if they're going down, that might also be another indication that we would get the feeding tube placed. Okay, so we specifically are looking at that forced vital capacity. Oftentimes, doctors will start bringing it up if that FVC is getting into even like the 70s or 60s, as a kind of a, hey, this is something we're going to be watching. If it gets more into the 50s, we may suggest going ahead and getting a feeding tube placed. Okay. And the biggest reason for that is we do have to go under anesthesia to get the feeding tube placed, and having a forced vital capacity less than 50% increases the risks of, complications from the procedure. And so if a feeding tube is something that's in your overall plan of care and you kind of anticipate this is maybe something I will need someday, if your breathing numbers are getting closer to 50%, the doctors will say, why don't we go ahead and get it placed? You might not necessarily need to use it yet, but it's better to have it placed when it's not a risky procedure. Versus, okay, now our breathing numbers are at 40. Oh, now we're starting to get symptoms of a decrease in swallow function. Then you kind of have to start having that conversation of, pros and cons of getting it placed when our breathing numbers are lower. Okay. And I'm not saying we haven't done it for people that have lower breathing numbers. We certainly have. But again, we'd rather be prepared and do things when it's not as risky. Okay. The PEG is the most common feeding tube placed for people with ALS, at least with Emory. So if we hear people talk about getting a PEG tube or a feeding tube, that they're usually talking about this PEG. Okay. Here's a picture of one. Some of them will look slightly different. Sometimes they have like a couple different ports, or sometimes they even have 3 ports hanging off of them. You'll see the tubing here, the internal bumper. That's the part that sits inside of your skin and into your stomach. Okay, and that's kind of how it doesn't fall out, is because this bumper is underneath the skin. Okay. You can see kind of a picture here of how it could hang off of the skin. Depending on which surgeon places the feeding tube, sometimes they're kind of shorter ones like this. Sometimes they're actually pretty long tubes. So they all can look slightly different, but it's kind of the same idea. You'll see the bottom picture here. You'll see just kind of this little kind of low profile feeding tube. So that's called a Mickey button. But what you do here is, instead of having a tube hanging off of you all the time, you have a separate tube that you just place into this little Mickey button when you need to do the feeding, and then you remove it. Okay. Depends on the person, the situation, which one they want to get. The surgeon will only place the one where the tube is attached surgically first. And then if you do want to switch to a Mickey button, you have to wait about 6 weeks after the procedure, and then it can get changed out to that. Okay. But anytime you're initially getting the feeding tube placed, it would be the one that has the tube attached. Okay. Most individuals that receive a PEG tube do continue to eat and drink through their mouth. Okay. I'm not saying I don't have patients that only use the feeding tube for nutrition. I do, but there are certainly the majority of people are at least getting to do some things by mouth. Okay. And it runs the gamut from, you get the feeding tube placed because of breathing numbers and no other reason, and you get to eat and drink as much as you want by mouth and have no problems, and you never use the tube, to, okay, I can eat and drink my calories, or I can eat my calories, but I have trouble getting my hydration. So I make sure that I get some extra hydration through the feeding tube. And then, I can have people doing 1 carton of formula through the feeding tube up to, the maximum amount for their calories. So 5, 6, 7, 8 cartons. Okay. Insurance oftentimes will start covering the cost of the tube feeding formula and the supplies once it becomes like your primary source of nutrition. Okay. That is something that is kind of up to how you're feeling at home and how the nutrition is going at home. We usually have to have the doctors evaluate this and then, put something in the charting system saying that this is going to be a primary source of nutrition. And then our team really helps to get that set up so that you aren't having to cover the cost of the formula because it can get pretty pricey. Okay. I've listed off kind of the 4 different types of formulas that we could be putting through the feeding tube. Um, Oftentimes people get started off on what we call just a standard formula, meaning it's got kind of the basic ratio of carbohydrates, proteins, and fats that we need. It's going to contain some fiber. It's going to contain the recommended dietary allowances for the vitamins and minerals. Okay, so it's considered to be a complete nutrition source. So this first one that I have listed here, there's one that says complete standard 1.4. That is a very common formula that I start people off on. Kate Farms is another one that I use often. Isosource and Jevity are other ones. Okay, there's more out there, but those are kind of the main 4 that I would most likely use. If for whatever reason these standard formulas don't work for the individual, then we start looking at different specialized formulas. Okay. And these ones might have just nutrition compositions that are designed to help manage other chronic conditions. The most common one I see for people is diabetes, right? They had diabetes prior to the disease. Now they have a feeding tube. They're put on a standard formula that, isn't really, really high in carbohydrates, but higher than maybe their blood sugars can handle. And so they tend to see that their blood sugars start spiking up when they're using these standard formulas. So we then switch over to one of the diabetes friendly formulas that are a little bit higher in fiber or a little bit lower in carbohydrate ratios. And it tends to help their blood sugars. Okay, but there's also formulas for kidney disease if we needed it. And another one I often work with is like a peptide formula. So sometimes people come to me saying, anytime I have complete Kate Farms isosource, I get really bloated, or I'm getting a lot of diarrhea, or I'm getting reflux, or they're just getting kind of some GI symptoms. There's something called peptide-based formulas that are just a little bit easier to digest. And so they tend to feel a little bit better when they use those. So Peptamen is an example of that one. One that's really become more popular, I'd say, in the last 5 to 10 years are using blenderized formulas. And what these are is they look like a pureed food that you're putting through the feeding tube as opposed to kind of that like milk substance that like the complete or the Kate Farms would be using. Okay. And the ingredient list on the packaging, so like this is Liquid Hope is one of these, it would say chickpeas, spinach, blueberries, etc. Okay. So we will have like food ingredients that have been blended up into a consistency that can flow through the feeding tube. Okay. Some people will report, better tolerance with these formulas. So if they are getting kind of some GI symptoms, I oftentimes send people like this, the Peptamen or like the peptide-based formulas and also these blenderized formulas so they can try both of them and tell me which one seems to work better. Okay. The big kind of drawback to the blenderized formulas is that they're a little bit thicker. They sometimes don't flow through the feeding tube quite as easily. And so some people get a little bit frustrated just with the administration of them. I send some guidelines on how to administer them. And so I have patients that say this works great. I have no issues. And I have people say, no matter what I do, it's clogging up the tube. I can't do this anymore. So it just kind of depends on the person and the situation on what works best for them. And then from time to time, I have people wanting to make their own purees and administering those. And that is certainly something that we can support if that's something you're interested in. I do have, some websites and some videos that can kind of guide you through how to blend these up into that consistency that we want to be seeing to flow through the feeding tube. So I certainly don't have a problem with people wanting to do that. Most of the people that I work with use it as kind of a way to supplement. So let's say they say, okay, I'm going to do, 4 cartons of the complete standard formula, and then I'm going to do this one, 8-ounce container of a homemade puree. And I've just noticed, hey, they maintain their weight better when we're doing that. So again, it's something that some people do. The biggest hardship with that one is there's a lot of burden on the caregivers to create those and blend them up and administer them. So it's just a little bit more of a, like I said, kind of a task for a caregiver who is already doing a lot of other things. Okay. All right, I think that was all I had. So I tried to keep it fairly short. I didn't want to take up the whole time just with slides because I did want to make sure that I was able to answer questions for you guys. So thanks for being, an attentive audience, and hopefully we've got some questions.